Hi, I'm Dr. Jack West, medical oncologist at City of Hope Comprehensive Cancer Center in Los Angeles. This is West Wind, a podcast focusing on the intersection of cancer care, emerging technology issues in medicine, and healthcare policy. You can find information about subscribing at beaconmedic.com or wherever you find your podcast content. Please leave a review, especially if you like this, and we'd also love to get your feedback at westwindpodcast@gmail.com. We're continuing with the second half of my discussion with Dr. David Spigel, lung cancer expert and Chief Scientific Officer at Sarah Cannon Research Institute in Nashville, Tennessee. Here we focus on questions around the optimal duration of immunotherapy in responding patients, along with toxicity and cost challenges of long-term immunotherapy. Let's turn to the big question of whether there is some optimal duration of immunotherapy. You presented at ESMO 2017, the Checkmate 153 trial that compared the question of stopping nivolumab after a year in patients with advanced disease, advanced non-small cell, who had not demonstrated progression in their first year on treatment, continuing versus stopping after a year. And that demonstrated that there was a substantially better outcome, at least in terms of progression-free survival and a strong trend toward better overall survival with ongoing treatment. But a year later, at ESMO 2018, Roy Herbst presented the longer-term results from Keynote-10 that suggested that a subgroup of patients who went 2 years without progression on pembrolizumab continued to do well after stopping it, at least about 2/3 of the patients for a year or more and ongoing, and with about 1/3 progressing after that. So I found that Checkmate 153 was really influential in my practice and led me to continue patients basically indefinitely, at least until very recently, and even contact some patients about resuming it after we had stopped it earlier. What's your current thought process on this, and do you have a way to reconcile the differences between these conclusions?
Well, first of all, the Keynote 10 study was a very different study, where you get 35 weeks or 2 years of pembrolizumab, as you say. Whereas the 153 study was a study where you got 1 year of checkpoint inhibitor and then were randomized.
Right.
The Keynote 10 is much larger than the Checkmate 153, at least this subset that was analyzed. I don't make too much of 153. I think it was small. The numbers are certainly eye-opening, and I have to admit it changed the way I thought when the results came out, because I was a big believer in stopping folks who've had some kind of clinical benefit, and probably a year would be enough, and yet this study is slapping you in the face and saying don't stop. If you look at the swimmer plots in the control arm, there still are going to be people who do well stopping and getting re-exposed to nivolumab down the road, but it doesn't look like you'll know who that'll be. So there's a little bit of a sense of a gamble if I stop at a year that I may have made a mistake for a patient. I look at that set of data and I say, this should give you pause. It's not enough to set a new law for how we treat patients with immunotherapy, but it's enough to make us question what we're doing. The pembrolizumab data, both Roy's data and then the 001, actually melanoma subset, do suggest when you're doing well, stopping is okay and you'll continue to do well. And I think what I've been most compelled by are the deeper responses, the complete responses, that those patients who get deep responses, stopping is probably safe. I don't know what that is, though. Is that 6 months, year, or longer? And we all know stories of people who have stopped at some time point, were re-exposed and did well again. And I think it's just a big question mark right now. And you couldn't fault somebody for practicing, in a way that they thought was best for their patient. I think we're stuck for now following the literature. So if the studies with pembrolizumab went out 2 years in the first-line setting, like with 024 pembrolizumab alone, or 189 with chemo plus pembrolizumab. 2 years is the way we should do it. If it was treat until progression or some toxicity, that's what we should do. I think making things up as we go is probably not heresy, but it gets you into some trouble because we're not following the evidence-based data sets that we have.
I think one of the questions is whether there's any significant difference between nivolumab and pembrolizumab.
Right.
And a few years ago, we would have said that these drugs are interchangeable, and we've seen an emerging pattern of different results in the first-line setting in particular that have led me to walk back that conclusion, at least be less confident about that. Do you think that is a significant contributor here, that there's something fundamentally different between nivolumab and pembrolizumab, or that there are enough other potential differences in the duration of treatment and other factors that it's more likely that these other factors are the issue than the actual checkpoint inhibitor in question?
Well, I mean, the quick answer is there's no difference in these drugs, but you can't help but wonder if there is. And it's funny because, folks I care for will ask the question, what would you choose? Which drug would you choose? And I think we all would say pembrolizumab at the moment. I don't know. There's only so many things, Jack, right? If you have the same patient population by and large, and you do the same kinds of studies, and the only difference is one has pembrolizumab and the other one has nivolumab or atezolizumab, and the outcomes look best with pembro but not as good with the others, the only thing you could say is that the drug is different. We somehow seem to always be able to find differences in the patient populations and study design. And so there's still those nagging questions like, well, if they just designed Checkmate 026 like Keynote 024, it would have come out, the same way. And that may be true, but study after study in different disease settings, particularly small cell, non-small cell, do give you some pause about whether there are some fundamental differences in these drugs.
Yeah, I agree that I think we need to revisit that early conclusion that these drugs were as interchangeable as we thought they were.
And here's the other thing, Jack, whether it's true or not, that's certainly the perception.
Yeah. What about cost? I mean, I would imagine that cost is a big factor globally, but even in the U.S., and we're talking about the difference of treating for a few months versus a year versus 2 years or indefinitely. Has enormous implications for the budget for treating advanced non-small cell.
It's, these therapies are expensive. I heard somebody say, well, I would much prefer to use carboplatin, pemetrexed, and pembrolizumab over carboplatin, paclitaxel, and bevacizumab and atezolizumab. Don't forget, pemetrexed is not a cheap drug. And I know bevacizumab is expensive, but none of these regimens are cheap. They're all expensive. Unless you're giving generic chemotherapy alone, these therapies are extremely expensive. And, a lot of times we always just think of copay. Like, well, if my patient doesn't have a copay, then that's fine with me. But somebody's footing the bill. Yeah. Whether it's the government or some third-party insurer or otherwise, somebody is paying for these expensive therapies. And we've got to use these judiciously, and I think duration is going to be key. I shudder when I see these 4 drug combinations and 5 drug combinations. Like, do we really need to have to go there? And, to me, those have to be substantial improvements to justify, giving those kind of cocktails to folks. But that's what remains to be tested now. We're at a 3-drug regimen. Are we going to get to 4? I don't know.
Well, but you bring up the point that somebody's paying. I mean, when an insurer is covering it, that just gets passed on.
That's right.
As higher rates. And it's one thing if it is a miraculously effective therapy that
Absolutely.
we know you need to stay on. But when we really have no idea whether continuing a treatment beyond 6 months or 12 months after a very good response, or stopping after a year or two, is just as good as continuing indefinitely, this is a big issue when it's causing people who didn't get a vote on whether this drug was done. It was passed on to to people who just have rising premiums to pay and are really struggling at home.
Yeah, it's one of the challenges of drug development, I think, is this race to get new therapies out there, new, better therapies, but they're always going to be expensive therapies. And then what we don't do enough of is trying to walk it back. Like you get a drug on the market like nivolumab or Pembro or Tizo, and then trying to walk it back. Like, can you give it less often? Why does it have to be every 2 weeks? Well, let's get it every 4 weeks, but then double the dose. Let's, can we give it every 6 weeks or 8 weeks or 12 weeks?
Let's be honest. I mean, if you're the company who's selling it as an every 3-week therapy, you're not going to prioritize to see whether you can do just as well with every 6 weeks or stopping after 6 months of therapy instead of indefinite. And this is a setting where I think if there's a fifth drug in the market that is very, very similar, it's not likely to be way incrementally better head to head, but it may be able to show that doing 6 months of this therapy is just as good as doing indefinite pembrolizumab. And that is, I think, an opportunity that needs to be done. Because it's not in Merck's best interest to see how little pembrolizumab you actually need.
I know that's the fundamental problem you have is, you need these drugs to get out there to be developed. And in this example you've raised, Merck is our great partner in helping us get new therapies out the door. At the same time, like, can they be our partner in helping us figure out ways to do this in a less costly manner? And, are they motivated to do that? Probably not. It's difficult. I certainly see both sides, but I think there's still opportunities on the research side for us to do that kind of work. I know they won't be groundbreaking New England Journal paper types of studies, but they can, modifying therapies and figuring out how to make them safer for people and giving them, hopefully in a less expensive way, you still can do that kind of work without having to do 1,000 patient studies.
One thing that I've seen in many of my patients who are on immunotherapy for an extended period of time is musculoskeletal issues, just chronic new joint pains. And of course, this is somewhat hard to interpret because older patients with joint pains is not exactly electrifying or unique. And so it's hard to tease apart, is this just because they always had some knee problems and now it's worse? But I see a lot more of it than I thought, and it seems to, I would have expected. And it seems to be cumulative, and it sometimes gets a lot better when they stop their immunotherapy. Is that, my sense is that this is one of those side effects that is underreported because no one goes to the ER with chronic knee pain. But it's out there, and if you ask patients, you're going to see a lot more of it, and it may be something that is something to factor in when it's not totally innocuous. It's not just cost. It's actually quality of life for some of these folks.
So I'd put that in the same bucket as fatigue. Something I used to really, I'd never argue with patients, but I would really be skeptical when they told me they were tired. And now I'm convinced, that it plays a role. And I think skin issues, mild skin issues, can be troublesome to patients. And then the one that's been I've been most curious about recently, and I'm still trying to better understand it, is my belief that in elderly folks there can be some cognitive issues, and I'm trying to understand that a little bit more. It's not been borne out in the studies, and so it may just be an anecdotal experience. But I certainly had my share of elderly folks doing well and then not doing well, having cognitive things, not quite dementia, but some memory issues, and then some gait disturbances. Kind of reminds me of Parkinson's-like effects. I've heard others report it. I haven't seen or talk about it. I haven't seen it published, but I'm curious to know if that's something that we'll learn more about as we treat more people.
One final question I wanted to ask is, we have seen very impressive data on the combination of chemo and immunotherapy in 2018. It really totally changed the standard of care. And nowadays, it's really just a question of what histologically based chemo do you pair with immunotherapy, typically Pembro these days. But Now, those trials still had limited crossover, and only about half the patients ended up on immunotherapy at any time. And that's left me with the niggling question of whether it may not be the critical timing of giving everything up front, but just getting the drug. It's access more than timing. And so is this a study of first-line chemoimmunotherapy, or is it a study of 100% of people getting both chemo and immunotherapy versus only 50% of people getting chemo and then followed by
right. I mean, wouldn't that be the great study? Just carbo-PEM versus carbo-PEM followed by PEM. You know, my guess is if you could get, you know, that equal compliance to completion to the second line therapy, my guess would be that they'd be identical. That there wouldn't be any great differences in that. You know, the biggest argument you'll get, Jack, is, well, we lose 40% of our patients, or in some cases 60% of our patients, you know, as they're going through therapy, and they'll never make it to that next therapy, and you've denied them the chance of getting the best therapy up front. You know, I guess I accept that argument, because you do see things happen to people. You can't always plan it out perfectly. But, you know, fundamentally, if you had people who could get, even make it, you know, more simple, you know, nivolumab got approved in 2015, I think. If you just gave somebody carbopaclitaxel, they progressed, then give them nivolumab, would they live as long as somebody who got carbopaclitaxel and pembrolizumab up front?
Yeah.
And
I appreciate that. I think that certainly we've seen that in some studies. I'm thinking back to one, Torch by Dr. Gradelli, that if you give the wrong treatment up front, patients fall off and never get the chance. They do poorly. But I think that's particularly the case when you're talking about giving chemo after another therapy, whether that is an EGFR inhibitor or immunotherapy. If they're not going to be well served with the non-chemo option, there's an opportunity to drop off and never be as good a candidate for doublet chemo. Or we know that docetaxel rates of administration in the second line or later setting are 50%. At least they used to be when people wanted to give it. And but I would say that's not necessarily the case when you're talking about crossing over to an EGFR inhibitor in an EGFR mutation positive patient, or your threshold for giving immunotherapy. I mean, patients who can ambulate into clinic are fine candidates usually for these therapies. So I just don't think that is as tenable as this idea that you're only going to be a candidate for these therapies up front. That's probably more true for a platinum doublet.
I tell you, I had a little bit of a, I've wrestled a little bit with a couple of patients where I gave them pembrolizumab up front based on Keynote 024 because they were high PD-L1 expressors. I think they were 190%. And then they fell off a cliff. They did poorly by the first 3 weeks. Couldn't get any improvement with the second dose, and never really got a chance to get into chemotherapy. And when 189 came around, I said to myself, you know what? Maybe chemo is the way to cover my bases and prevent those rare folks that are going to drop off and not really respond, and then they get immuno anyway. And so, I'm still wrestling with, is that going to be the future of the best way to care for somebody? But when you have somebody on paper that should respond and then they don't, and you think, gosh, if I just given them chemo, I might have had a better chance at maximizing a response. 189 starts to make more sense. Keynote 189 being the combination of
carbo-pembro all together up front. And I agree that, with high PD-L1, you've got two competing good standards of care, and my inclination is to individualize based on the patient. Do they have a very high tumor burden and the actual amount of cancer? Have they been losing weight every week or two? Are they very symptomatic? These are patients where I don't know that it matters. Let's just give them every opportunity up front. If you cannot be very confident that
that's a good point.
6 weeks, 8 weeks, they are not going to have a very good performance status still, that's a patient where you just want to give them everything up front.
That's a great point.
If you could look at them and think, even if they progress, I'm so confident that they're going to be candidates for this in 8 weeks that we can do this.
And you're right. You can usually eyeball that and figure that out.
Anyway, thanks so much.
Yeah, Jack, it was fun.
Obviously big questions, and we haven't solved them all, but it's going to be an exciting few years to come. Thanks so much.
Yeah, thank you.
Thanks so much for joining me today for this West Wind podcast. We hope you'll be interested enough to subscribe either by checking out the options at beaconmedic.com or looking for West Wind Podcast on iTunes or wherever you find your audio content. Please take the time to submit a review, and we'd also welcome your feedback at westwindpodcast@gmail.com. Until next time, this is Dr. Jack West. Thanks for listening.